This is Audible Bleeding, the vascular surgery podcast. We're here to help you keep your finger on the pulse.
Okay, and welcome back to the Behind the Knife and Audible Bleeding Vascular Trauma podcast series with our guest, Dr. Todd Rasmussen. Dr. Rasmussen is a colonel in the United States Air Force and is a professor of surgery and associate dean of research at the Uniformed Services University of Health Sciences and an attending vascular surgeon at Walter Reed Military Medical Center. Thank you, Dr. Rasmussen, for coming back on the joint podcast to help us learn about trauma.
Sure. That's a pleasure, and I look forward to some of our discussion. Thank you.
We're lucky enough to have one of my partners, Dr. Adham El-Musli. He's a chief resident at Cornell, and he'll be helping us with this interview. Thanks, Adham.
Thank you. I'm happy to nerd out about some surgical technique with a master here.
So we're going to drive straight into abdominal venous injuries, and we're going to keep it simple here. When we're thinking of abdominal venous injuries, we're going to think of three types. You have your IVC, you have your portal vein, and you have your superior mesenteric vein. So we're going to break these down in order and discuss the approaches to exposing it and fixing it. So of these, Dr. Rasmussen, what do you see most commonly?
That's a great question as to which we see most commonly. I think they're all relatively uncommon because of the frequency of blunt trauma, especially in the civilian setting. I suspect that blunt liver injury and the relationship between the liver and the vena cava is probably the most common.
And are isolated injuries to the IVC, is there any non-operative management that's amenable for the IVC?
So I think, yes, I think there's a number of types of injury scenarios that would be amenable to non-operative management. We just mentioned very briefly the retrohepatic caval injuries, and in fact, most of the time, if the patient can be stable and doesn't have other associated injuries that require exploring that area of the vena cava, oftentimes retrohepatic vena cava injuries should be managed non-operatively. And that's, of course, because of the difficult nature of exposing that area of the vena cava and the high risk of causing more bleeding with that exposure. Because the venous system, the vena cava, is a low pressure system, infrarenal vena cava injuries, suprarenal vena cava injuries, or even suprahepatic can be well tolerated, the non-operative management, because it's a low pressure system. But in particular, the retrohepatic portion, I think, is particularly amenable to non-operative management.
So you kind of touched on this a little bit, but when we talk about the IVC, we sort of divide it into four segments anatomically because each of them has their own implications and difficulties. The infrarenal segment, the suprarenal segment, and then the retrohepatic and suprahepatic segments of the vena cava. I think it's probably worth going through each of those segments and discussing briefly exposure, and I think we should spend some more time on retrohepatic, but discussing exposure and then strategies for repair versus ligation and their implications in each of these segments.
Okay. Yeah. So I guess we'll start with the infrarenal segment of the vena cava. That's probably the most easy to expose. The infrarenal vena cava segment is best approached through a right visceral rotation, meaning bringing the right colon, the cecum, and the viscera up cephalad in the retroperitoneal space to expose the vena cava in the infrarenal segment. And that maneuver at its proximal most extent will expose the renal veins, the fourth portion of the duodenum, and the pancreatic head. So that's the best way to expose that. And then I think repair options there, it depends upon the severity of the injury. If it is partial injury to the vena cava, then hopefully primary repair. The vena cava is quite large. It has a large capacity, and controlling that and repairing an injured segment primarily with 4-O-proline suture, for example, is pretty well tolerated. If one feels like they're going to narrow the vena cava significantly, then that's a different consideration, which includes then should the vena cava just be ligated as opposed to trying to repair the vena cava and leave it narrowed, which then would predispose it to thrombosis and potentially life-threatening thromboembolism. So that's sort of this infrarenal segment. I mean, we could talk an hour on this segment of the vena cava. Control is challenging because it bleeds black blood in large quantities. And oftentimes controlling proximally and distally is not enough because there are lumbar vessels, the lumbar veins that are back behind, that if one doesn't control one of the large lumbar vessels that's coming into the vena cava posteriorly, you can have all the proximal and distal control that you want, and you still can't see anything because you've missed a huge lumbar vessel that's, lumbar vein that's feeding from the backside. So one has to be mindful of that and try to either identify that and get it with a clamp of some sort, or get around it with a vessel loop or something to control it. As we have said in other of our discussions, none of these operations or these techniques take place in isolation. They've got to be done in close communication with anesthesia, and assure that anesthesia is not only adhering to the principles of damage control resuscitation with you, but they're also aware of these maneuvers, whether it's losing large volumes of black blood from the vena cava, or maybe ligating the vena cava in the infernal segment, which is going to significantly reduce the inflow to the right heart.
So 2 follow-up questions on the infrarenal cava. In general, you said you use a 4-0 pulling to repair the cava. Do you have a specific needle? Probably a larger needle is better. And then the second question is, when you're doing the infrarenal cava ligation, do you think we should be empirically doing 4-compartment fasciotomies on these patients?
Yeah, so really a good point about the needle size. So I think a 4.0 on an SH needle is imperative. So these are the subtle parts that I think before someone tackles this needs to have in mind. Generally, you need 2 large bore suckers. You got to have headlights. Make sure you have hands, extra set of hands, because you may only have 1 or 2 shots at this. Controlling it and seeing where the bleeding's coming from, and to the best you can, don't waste one of those opportunities, because what you're going to be able to do is control it with, for example, sponge sticks or even your hand. So, while you've got it controlled, then make sure you've got the right lights, the right suction devices, the right assistance, blood in the room, all of those things. Take a deep breath and get all that squared away. To your point of a needle, the point here that we're talking about for your listeners is don't use too small of a needle. A common mistake is this has got to be a dainty needle. It's got to be small because they're sewing on the vena cava, maybe a 5.0 or 6.0 Proline. I'll put it on an RB1 or C1 needle. These are small needles. Then what happens is that needle, you can't see it in all of the blood. So an SH needle is really designed with a sort of a large arc that really can literally go underneath your finger, and a 4.0 Proline will go on an SH needle. So absolutely. As far as the empiric performance of 4-compartment fasciotomies with ligation of the vena cava, I'm going to take a pass on that and say it depends. I think it depends upon how much resuscitation the patient's received, meaning if they've received large volumes of fluid, they're physiologically not well, and you anticipate a large sort of significant recovery burden, then yes, I would probably do fasciotomies of the lower extremities and elevate those legs and do everything you can to keep the pressure down. In contrast, if the patient's physiologically pretty well, that was a relatively small resuscitation, then perhaps not. I think it just depends, but you should be definitely mindful of it. There's no doubt. And if you don't do the fasciotomies, recognize that you got to keep an eye on the leg and keep the legs elevated.
So, Dr. Rasmussen, I have to thank you. We actually kind of talked about managing IVC injuries in our first episode. So this is our 3rd episode total. We've covered lower extremity injuries, we've covered abdominal aortic vascular trauma, and today's our venous. But on our first episode, we talked about using the large 4.0 needle. And about a week after that episode, we got called into a internal hemipelvectomy case, which I didn't even know was a case, where the orthopedic surgeons were resecting this massive sarcoma off the pelvis and basically resecting half of the pelvis. And they got into massive bleeding. Basically, they had gotten into the crotch of the IVC and had just exsanguinating hemorrhage every time they removed their hands. And using the large 4.0 needle, the large needle and the 4.0 suture was really helpful, A, because like you said, it helps you see it through all the bleeding. And then the thing that's nice about the 4.0 is you can really kind of crank down on it and push your knot down there without worrying about it breaking. And when you're in this case with lots of bleeding and there's 5 people around the operating table, I found it really helpful. So I thought straight to that episode right when we were in that case.
Good. Glad it was helpful.
You mentioned in your book chapter, which I also have seen in some liver cases where injuries to the cava are made, that's helpful, is when you're placing these sutures into the vena cava, if you're doing a figure of 8 or a figure of 16, placing the first suture and then lifting on both of the strands of the suture up in the air to elevate the hole and get some control, and then maintain that tension as you place the rest of the suture.
Yeah, that's an important part. And I think, I would go back to the fact that, you're only going to get 1 or 2, maybe 3 chances at this. So, don't skive. Don't be afraid to take too big a bite. You got to get substance of the vessel, and you got to get the bleeding controlled, or you're just not going to get to the next step. So, so making that first pass that you think, well, this could be a figure of 8, it's a little bit behind. It's not complete. I'm not advocating for taking Hail Mary. I'm not saying that, but the point is, be definitive about your suture placement, and go ahead and get full thickness bites of the vessel wall. Then pull up on that, and that may help you expose. Each injury is a little bit different, but try to recognize that in order to get through it to that next step, you're going to have to get full thickness bites of even the vein, and in fact, especially the vein, right? Because it's going to be more prone to tear. So you really can't skimp on these sutures.
And so once you go above the renal veins, the ability to ligate completely changes, and everywhere above that. So can we talk a little bit about the anatomy of the suprarenal, and then just briefly discuss retrohepatic and suprahepatic IVC?
Right. So I guess we didn't really mention but the reason that the infrarenal ligation can be tolerated, it's not ideal, but patients will survive with ligating the infrarenal, is because one has not disrupted the venous outflow of the kidneys. So with an infrarenal ligation, flow through the left and right renal veins is maintained, and therefore kidney function is still preserved. That, as you reference, changes when the injury is above the renal veins in the suprarenal segment of the IVC. And in those cases, you're right, ligation really isn't an option. This is a very small segment. This is only a 2 or 3 centimeter segment of the IVC, between the superior aspect of the renal vein and then the initiation of the drainage of the hepatic veins, the retrohepatic. So this is a very small segment. And, I think that if there's an injury in this segment, it should be, attempts should be made to primarily repair it. If you find yourself operating on it, this also gets in this area where it really could also be almost considered retrohepatic. And certainly if these are blunt injuries or from a blunt mechanism, you may not want to find yourself operating on that if the patient will give you that option.
So if you do find yourself needing to operate on this, obviously you need to mobilize the liver to expose this part of the vena cava. What considerations do you need to take into account before mobilizing the liver, and can you walk us through your technique in doing so?
Yeah, I think effective mobilization of the liver cannot be overstated how important that is, because to get enough control of the vena cava in this segment really requires dividing the attachments of the liver to the diaphragm and getting the liver, mobile so that it can be moved cephalad and allow exposure of this segment. So I think what to be mindful of is in this area, this is just a very difficult area, because inevitably there are lumbar veins coming from the backside of this aspect of the vena cava, and inevitably to control the cephalad portion of this area, there's likely to be a couple of hepatic veins that are coming into this area. So it is, mobilization of the liver, I think, is very important to allow exposure. I think we mentioned, I guess, to start, the medial visceral rotation of the right colon and the head of the pancreas. All of that has to really be, I think, maybe to your point, make sure that exposure is also very thorough, so that the third and fourth portion of the duodenum or head of the pancreas are lifted up off of this segment, so that one can really expose and see. As we said at the outset, it's difficult to sew what you can't see,
And I think one point that we haven't emphasized enough here, that you emphasize in your book substantially, is the fact about really being careful about your decision to mobilize the liver and how you can really make your situation worse. Can you touch on that?
There are some injuries where actually leaving the liver is, of course, retrohepatic. If you get into the retrohepatic segment, then in those situations, often leaving the liver in place is ideal because it's what hemostasis may be attainable is by don't unroof the tear in the vena cava behind the liver. So in those cases, actually leaving the liver and not mobilizing it might be beneficial and should be the route that's pursued. In contrast, if this is injury to the suprarenal segment of the IVC, it's a longitudinal tear, and you sort of see it that it's there. It's not a retrohepatic segment, then, and you see the bleeding is from below the liver in the vena cava. Then, those situations, and mobilizing the liver to a degree is actually maybe necessary so that you can control above the injury of the hepatic veins. The suprahepatic vena cava is that is the fourth portion. So we've talked about the infrarenal, the suprarenal, the retrohepatic, and then the suprahepatic. That is exposing that. There's also a pretty short segment there from the last of the renal veins and the phrenic veins that drain into the vena cava right at the crus, and then the right atrium of the heart and the pericardium. So that's a pretty short segment there. To expose that area, one needs to really divide up along the xiphoid to really get the costal margins to open up. To just go from a tip of the xiphoid to the pubis, often it is not enough. Really, in my experience, takes a concerted effort to divide up along the edge of the xiphoid 2 to 3 centimeters cephalad, separating the xiphoid from the right costal margin to really open that up and show all of the diaphragm, and at the base of that, of course, will be the vena cava, and that's sort of that fourth segment, if you will, that we have discussed of the vena cava.
Okay, Dr. Rasmussen, at least in a lot of my training, I've been taught with a large bleeding IVC to get proximal and distal control sponge sticks. In your book, you have some precautions that you mention against this technique, and how do you recommend approaching a kind of a bleeding inferior vena cava?
So I think the tenet of the sponge stick is the same whether you use the sponge stick or your hand or a finger or another instrument. I think it's the starter, right? You're trying I got to start somewhere, and there's this black blood welling up. I've got to get pressure on it. So that pressure can be applied with a sponge stick or a hand. I think what one recognizes that whatever you use for that initial application of pressure, you're going to have to refine your dissection. You're going to have to refine your exposure. And then you're going to have to refine that manual pressure mechanism, because you can't operate. Everybody's got their hand in the wound. It may not be bleeding, but you can't be there forever, and you can't see to actually dissect and expose and operate. So I think the sponge sticks are fine. I think so we don't skip over it. If this is a retroperitoneal hematoma from the inferior vena cava, this has got to be exposed, in my experience, through visceral rotation of the right colon, the cecum, and the right colon up to the patient's left, exposing the vena cava. You won't be able to manage this hematoma by going through the mesentery of the right colon, for example. That's a premise that this injury's got to be managed with a medial visceral rotation of the right colon and cecum, cephalad into the patient's left to expose this injury. Even if you start out with a sponge stick or manual pressure before that maneuver, let anesthesia catch up, get blood in the room, but eventually you're going to have to mobilize that cecum and right colon up and to the patient's left. I think from there, these technical tricks that you're referring to, I think trying to get the application to something smaller than the sponge stick. So oftentimes something that's referred to as a Kittner or a peanut, if you will. Those are lower profile. You can see around them. Often you can sew around them. They're smaller than the sponge stick. And oftentimes use of those, which is really the similar principle of manual pressure, is, I think, useful. I think while you have the sponge sticks in to the degree that one can get proximal and distal control of some of the large tributaries feeding the injury area, the iliac veins, then that may be useful as well. The other technical tenants are you're going to need probably 2 large bore suction devices, lights, blood in the room. Don't overlook those things, as we have said in a couple of our other segments, this is the type of injury where you may only get one or two chances at this. You want to make those chances as good as possible. So, the sponge sticks are fine, but they're only going to be a starter, and you're going to have to refine your manual pressure to something smaller so that you can dissect and expose, so you can actually find and then address.
So we were talking about retrohepatic cable injuries, and a technique that we didn't discuss that may be useful in situations where there's blood welling up from behind the liver and it's not clear where it's coming from is total vascular isolation or total vascular exclusion. Can you walk us through that?
Yeah, it's a good point. And I think we haven't mentioned that. And of course, that is trying to isolate all the flow to the liver and reduce bleeding ultimately from the cava and the confluence of the hepatic veins. So, if one thinks about the inflow into the liver, right? So that it would be the portal vein, which is probably 70 to 80% of the total flow. So trying to isolate the portal vein and being able to control at least and isolate the porta hepatis and the portal vein, the hepatic artery through what's called the Pringle maneuver. So that's really the inflow to the liver. And then as far as that segment of the vena cava, controlling, the vena cava and the renal veins below that injured segment, the other portion of inflow. So going through those steps to isolate what is inflow into the liver and that injured segment of cava where the confluence of the hepatic veins is, that's sort of the key tributaries that need to be accounted for in that maneuver.
And then when you're above the injury in the suprahepatic cava, are you getting control in the area of the confluence of the hepatic veins below the diaphragm, or do you find that you need to go into the chest and get control of the cava in the chest?
Yeah, so that's a great question. I think when doing total hepatic isolation, the one segment, which is the suprahepatic segment of the vena cava, I tend to cheat. The question was, do you go into the chest to control that segment, or can you do it through the abdomen? I always do it through the abdomen. But when I say I cheat, I suspect by the time that I have done it, I've divided the xiphoid up along the costal margin and almost started what amounts to opening the chest through the abdomen, because you're exactly right. You have to get pretty high and using some deep, what are referred to as long renal vein retractors, the Wiley renal vein retractors that are handheld. Those can go down onto the cruce as it covers the vena cava, and you're basically in the chest. You're just in the chest through the superior most aspect of the abdomen. I can't emphasize in those situations how important it is to have released the hepatic attachments to that portion of the diaphragm, and then really spread those costal margins out. The costal margins, they tend to enclose around the abdomen. That's what they do. But by dividing the xiphoid 3 to 4 centimeters cephalad, it's often overlooked. But that really allows you to almost suspend the patient with retractors under the costal margins. And that really, in a way, puts you in the chest, although you're there through the peritoneal cavity.
And just for completeness sake, to totally cover total hepatic vascular exclusion, if you still have bleeding after getting the suprahepatic and infrahepatic control and the Pringle, is there an option to prevent any further flow? I'm alluding to the point in your book where you talk about, in this very rare situation, you can do a supraceliac aortic clamp to help identify the injury, but the patients are unlikely to survive this.
Correct. I mean, I think there's a couple of damage control steps. You can certainly clamp the aorta to see if that helps. I mean, I think that's absolutely a great point, and I didn't mean to overlook that. If nothing else, oftentimes clamping the aorta is needed to support left ventricular, afterload for a period of time, because these patients are in rough shape. So you may need to clamp the aorta as a resuscitative maneuver anyway. And you may see that helps or doesn't help. The other situation is trying to then place that then bypasses, from the inferior vena cava up into the right atrium. These are very rare, but that is a way to then bypass the liver and allow continued inflow right heart from the infrarenal segment is by using a shunt. So that has been described as the Shrek shunt, and most commonly is described using a chest tube, and that can be used as well as another sort of last, I don't want to say last ditch effort, but at that point, like clamping the aorta, you're pretty well down on the list of things that you are trying to do.
So does the Shrek Giant belong to the history books, or is it still a viable option?
I think it is still a viable option. I mean, it's extremely rare, but I would advise all surgeons to learn about it and to understand what it is. I think it's unlikely that we'll find ourselves in those situations, but any of the shunting techniques, the temporary vascular shunts, I think it's important to familiarize oneself with the principles and to have in mind the situation in which it might be useful. So I don't think it's not any more condemned to the history books as any other modality of temporary vascular shunting.
Great. And so as we're starting to wrap up our venous episode, we've covered the 4 segments of the vena cava. And just to recap, that's our infrarenal, which we can repair, we can interposition, we can ligate if needed. And then we have our suprarenal, retrohepatic, and suprahepatic, which are quite challenging injuries, which we discussed in detail on kind of bailout maneuvers for those. Now we're going to talk about our portal vein, which also includes our superior mesenteric vein and options in this situation. So obviously, if possible, we're going to, repair an injury. And obviously, like we've said many times, these injuries do not happen in isolation. There's probably multiple other injuries to the pancreas and celiac artery and who knows what else. But can we just discuss, if you have a portal vein injury, you're probably in a pretty catastrophic situation. Can you ligate it? Can patients tolerate this?
I think that's going to be tough. So I suppose they can tolerate it. And like any damage control vascular scenario, ligation is an option, and it may be necessary. But I think ligating the main portal vein carries with it a very high mortality. So I would, if I would consider, temporary vascular shunting, if at all possible, although that's obviously pretty rare. If it's ligated initially as a damage control maneuver, is just trying to get things stopped, then I would get the patient resuscitated and then I would try to reconstruct it, because I don't think long-term the ligated portal vein it's very unlikely to be survivable. So if, for example, let's ligate it, let's get the bleeding stopped, let's get another set of hands in here. Okay, we've got the bleeding stopped. It looks like the portal vein's now ligated, but let's get the patient resuscitated, a little bit warmed up, and let's look to now reconstruct the portal.
And you mentioned in your chapter about for these injuries, it's very likely you may need to divide the pancreas if the projectile hasn't divided it for you to help get better exposure to repair. One thing I thought was really interesting in your chapter is you discussed how there's very limited experience with these injuries and not a lot of follow-up. But the thought is that with our current anesthesia techniques and our open abdomen techniques, that these injuries may be survivable when they weren't in the past. Can you talk a little bit about the blood return from the splanchnic circulation and why it's important to discuss that with anesthesia and options if you do have to do an aggressive ligation or repair of this vessel?
Well, I think if I understand your question, as these torso-vascular injuries are the most complex. And as we have discussed throughout our talk about vascular trauma, the reconstructive technique, whether it's a damage control technique or a definitive repair technique, needs to be done in conjunction with anesthesia and the resuscitation team. And that's to assure that the tenets of damage control resuscitation are being pursued by the team, meaning blood and blood component replacement, prevention, coagulopathy, mitigation of acidosis, optimization of ventilation, all of those things. So I think the more complex the vascular injury, the greater the consequences with that vascular injury, the more important it is that we're communicating with the anesthesia team to let them know what we're doing and considering with regards to, in this case, these whether it's a portal vein injury or a superior mesenteric vein injury. It's important so that damage control resuscitation occurs with damage control surgery. One without the other is going to fail. If you do perfect damage control surgery, but you failed at the tenets of DCR, damage control resuscitation, it's not going to work, and vice versa.
And so just to wrap up the portal vein, and we kind of looping in the superior mesenteric vein into this, ligation is really not tolerated, but in a catastrophic situation, you can consider it, as long as there's communication with anesthesia, that 50% of the blood volume is going to be sequestered in the splanchnic circulation. And then with management of open abdomens and aggressive fluid resuscitation, there have been case reports of survival after portal vein ligation. So Dr. Rasmussen, once again, we took you through a lot of vascular trauma today, and you were very patient with us and breaking every detail down. We really appreciate this, and we think our listeners will also.
Thank you very much.
Well, I appreciate the opportunity, and I commend you for tackling such a complicated topic. And I hope that it's useful, and would encourage, as we've said throughout our discussion, encourage your listeners to get an atlas or a video and augment our discussion, with other learning techniques.
This is Audible Bleeding, and now we have t-shirts. If you enjoy Audible Bleeding, please support our work by providing feedback. For a chance to win one of our t-shirts or a $50 Amazon gift card, fill out our listener survey found on audiblebleeding.com.